Can you hear me now?
Yes, I can.
Okay, good. This is Norman Kahn, Executive Vice President and CEO of the Council of Medical Specialty Society. I'd like to welcome you all to this particular webinar. CMSS, with our 43 members, represents 790,000 physician members in the United States and have two priorities. One is quality and performance improvement in practice. The other is professionalism. And this morning, we're really looking forward to this particular webinar as MACRA is clearly an issue. We're trying to prepare all of the members of our member societies for the new quality payment program. So with that, I'm going to introduce Leila Volinsky, who is Senior Program Administrator for the New England region of the Quality Payment Program, and we'll learn about MACRA and our choices. Thank you.
Thank you so much, Dr. Kahn. My name is Leila Volinsky, and I will be leading you through Conquering MACRA for Specialists. Chart your own course. Before we get started, I just want to inform you all this content comes directly from CMS-generated materials. However, as a contractor for CMS, we put these slides together. A quick overview of what we'll be talking about today. I'll give you a brief overview of MACRA. We'll talk about eligibility and exclusions, the reporting pieces under the MIPS program, the MIPS performance categories, how you should start preparing, APM special considerations for those of you participating in alternative payment models, some resources, and then we'll allow time for questions at the very end. As many of you know, CMS loves to use acronyms. You'll hear many acronyms throughout our call today, so here's a quick list of what you'll hear probably most frequently. We'll start with CMS, the Centers for Medicare and Medicaid Services, MACRA, the Medicare Access and CHIP Reauthorization Act, MIPS, the Merit-Based Incentive Payment System, QPP, Quality Payment Program, APM, Alternative Payment Models, IA, Improvement Activities, ACI, Advancing Care Information, and EHR, Electronic Health Record. MACRA was introduced in April 2015. It's legislation that received strong bipartisan support and repealed the sustainable growth rate formula, which had been in place for a long time and led to much concern from many clinicians about how they would be reimbursed for their Medicare services. With the repeal of the sustainable growth rate also came the creation of the Quality Payment Program, or QPP. And under the Quality Payment Program, there are two performance tracks, either MIPS, which is the Merit-Based Incentive Payment System, or APM, Alternative Payment Models. Under the MIPS track, clinicians can earn positive payment adjustments based on their performance, and we'll talk more about what the percentage is for that. There are 3 reporting cases, which we will also talk about in a minute, and if clinicians do not choose to participate, they will receive a 4% negative payment adjustment on all of their Medicare Part B claims. Clinicians participating in alternative payment models, there's 2 tracks, either MIPS APMs or advanced APMs. If you're part of a MIPS APM, you actually are still sort of in the MIPS program and would receive favorable MIPS scoring and a MIPS payment adjustment. If you are in an advanced alternative payment model, you follow a risk-sharing structure and you can receive up to 5% lump sum incentive payments. So as I mentioned, under the Quality Payment Program, there are these 2 tracks, MIPS or APMs. The MIPS program consolidates 3 legacy reporting programs, which you might be familiar with. The first is the Physician Quality Reporting System, or PQRS. The second is Meaningful Use. Some of you might know that as the Medicare EHR Incentive Program. And the third is the Value-Based Payment Modifier. All of those programs have since gone away, and now you will just be reporting under the MIPS program. Again, if you're part of an alternative payment model, there are 2 tracks, MIPS APMs, which do not take on the downside risk. Those, for the most part, are the Medicare Shared Savings Track 1 participants. There are also advanced APMs, as I mentioned, which take on upside and downside risk sharing. Those are the Medicare Shared Savings Tracks 2 and 3 participants. Next generation ACOs, comprehensive primary care plus model, the comprehensive end-stage renal disease model, oncology care model, and if you're in an advanced APM and you don't meet the qualifying participant threshold, you do have the option to participate under the MIPS APM model if you would like to receive an incentive. You are not required to participate, but if you choose to receive an incentive, that's an option for you. For the MIPS financial impact, clinicians that participate would submit data for the performance year of 2017, and based on their performance, would receive either a positive payment adjustment or negative payment adjustment on their Medicare Part B claims 2 years later. So performance year 2017 will receive payment adjustments in 2019, and so on. As you can see by this graph, the payment adjustment amount steadily increases. So it's 4% in 2019, 5% in 2020, 7% in 2021, and up to 9% in 2022. Now, many of you might be thinking 4%, even 9% might not seem like a lot to have a negative payment adjustment or a positive payment adjustment for that matter. But if you think about how much that actually impacts your practice, that might be a part-time staff member's salary, or it might be how you're affording to bring in a new piece of equipment. So really think about the bottom line and how that money could affect your practice. Eligible clinicians in this program are considered to be those who are physicians, so medical doctors and doctors of osteopathy. They're also dentists, dental surgeons, chiropractors, surgeons, and podiatrists. Physician assistants are also included in that, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. So CMS has really opened up the criteria for who is considered an eligible clinician under MIPS, whereas TQRS and Meaningful Use really limited that mostly to physicians alone. Under this program, there's also a low volume exclusion, so clinicians that submit fewer than $30,000 in Medicare Part B claims annually or see fewer than 100 Medicare patients annually would be excluded from the program. If you can say no to either of those or below that threshold, you would be excluded. If you say yes to both, then you would be included. CMS has a very helpful tool that will look to see if you are included or excluded. If you click on this link, https://qpp.cms.gov/participation-lookup, you can actually look up your NPI number and see if you are either expected to report or excluded from reporting in 2017. Some of your practice managers or organizational administrators might have received the letter that's on the right-hand side of the screen. This was sent, I believe, at the end of May, sometime in May of this year, and it includes the TIN of your practice, so it's the tax ID number of your practice, and any NPIs, so those National Provider Identification Numbers, in the practice that are either included or excluded. So there's a list. It'll show you this TIN has this many NPIs affiliated with it, and these NPIs are either expected to report or excluded. Now, that might have changed. It might not be accurate. The best way to check is this NPI lookup tool that I mentioned. As part of the lookup tool, CMS also includes a special status determination box. This is extremely helpful. So those clinicians that are either considered to be non-patient facing, so potentially pathologists, radiologists, in some cases anesthesiologists, you might be considered non-patient facing and should check what your status is on the determination screen. If you are considered non-patient facing or hospital-based, you have slightly different requirements for reporting under MIPS. In those determinations, those clinicians are not expected to report advancing care information data, which we will talk about in a minute. They are allowed to be completely excluded from that category. As you can see on this screen, there's actually a determination for clinicians as well as for the practice. For a practice to be considered non-patient facing, at least 75% of the clinicians within that practice must be considered non-patient facing, and for hospital-based determinations, for the practice, the whole practice, 100% of the practice must be considered non-patient, hospital-based, For small practices, rural practices, and health professional shortage area practices and clinicians, those clinicians and practices have reduced requirements in terms of their improvement activity requirements. If you're considered a small practice, rural, or HIPSA practice, you would only need to report on 1 to 2 improvement activities to earn full credit. Again, we'll talk about improvement activities a little later on. Under the MIPS program, there are 4 performance categories. Only 3 are scored for the 2017 transition year. Quality, which we'll get into more, but it accounts for 60% of the MIPS score. Advancing care information accounts for 25% of the MIPS score. Improvement activities, that's a new category, accounts for 15% of the MIPS score. And cost is 0% for this transitional year, as I mentioned. With the final rule for MIPS, there were some additional flexibilities allowed for clinicians in this 2017 reporting year. CMS is calling this the pick-your-pace reporting options, and I'll go through the various pieces now. If you choose to do nothing, you completely forego reporting, you will earn a negative 4% payment adjustment on all of your Medicare Part B claims in 2019. I would highly recommend that you not choose this option. We are here to help and make sure that everyone is successful. The requirements to avoid the penalty are relatively minimal, so I will talk about those more, but please try to report on something. If you choose to report the crawl pace, as we call it, CMS calls it tests, where you're testing out the program, you would earn about 3 performance points. You have 3 different options here, so you can select to report on 1 quality measure for 1 patient for 1 time. That is the absolute minimum amount of data. If you choose this option, I would suggest that you report for at least 20 or so patients. That way, if, let's say, one of those patients, the one maybe that if you did the 1 instance, was excluded for some reason from that quality measure that you had selected, you would then fall into the non-reporter group. So if you have 20 patients, a handful maybe are excluded due to differences in eligibility than what you had initially thought, you would still have some patients to support your reporting efforts. That's anywhere from a single instance up to 90 days or so for reporting. If you select to report on 1 improvement activity, you must report for at least 90 days. And the final 90 days of the year starts October 2nd. So we're coming up on that last 90-day period very quickly. You can also select to report on the required base advancing care information measures, which we'll talk more in a minute about. Those also have to be reported on for a full 90 days in order to receive the exclusion from the negative payment adjustment. If you choose the walk pace, you would earn 4 to 69 performance points. Through this reporting pace, you would select up to 6 quality measures. At least 1 must be an outcome or high priority measure. You could select 1 to 4 improvement activities. That's depending, again, on your practice size and the weight of each of those activities, which we'll talk about more later, and the required advancing care information-based measures. Under this pace, you would report for a minimum of 90 consecutive days, and again, that must start no later than October 2nd. By reporting and earning 4 to 69 points, you would earn a small positive payment adjustment. If you choose to report for the most amount of time and earn the greatest number of performance points, you would be in what we consider the run pace. This is the same requirement for quality measures, so up to 6 quality measures, 1 to 4 improvement activities, and still the required base advancing care information measures. You can report anywhere from 90 days to a full calendar year. But the key piece here is that you're earning at least 70 performance points. By earning at least 70 performance points, you would earn a moderate passenger payment adjustment, and you would have the opportunity to receive separate bucket receipts as assigned for effective performers. That's about $5 billion that's been set aside again for exceptional performers. The percentage out of the payment get additional money. What else is from the so specialist perspective? We've got some specialists can't find quality measures specified to my practice or even that I care for. We've talked about quality measures and the specialty measures that depending on what specialty is might be like the specified to. Hopefully we can help you out about that. So here, I've heard of the multi-specialty group. How do you tackle the measure? What if you're a practice that has, let's say, 2 to 6 different specialties and they can select quality measures, but those 6 measures really should be the clinicians you have. Well, hopefully we can help with something to improve that. Are the for sure. You have some recommended improvement activity, but for this there's we'll have for that are hopefully you'll find some that you all the patients that you're facing. Quality percent of your scores, these are carry over from the physician reporting system program to the 70 with the maximum score is reporting on specific quality measure. Again, have at least one out on a high priority measure. That's just see what's on the next slide. Data can be reported again, but little as an instance, you'll focus underneath. If you choose to report for 9 days, you must start that 90-day period no later than October 2nd. Under quality, there are several submission options. If you choose to report as an individual, you may select claims-based reporting, but that is only available for individual reporting. You can also select to use your EHR if it has the availability of this option. Some EHRs are not equipped to report directly to CMS or might charge a fee to use the service, so be sure to check with your EHR vendor to see what's available. If neither of those options work for you, you can also consider using a registry or qualified clinical data registry, which is QCDR. Again, QCDRs and registries have options for clinicians both using electronic health records as well as paper reporting. So depending on where you are in your practice, that might be a more viable option. Keep in mind, though, that oftentimes registries do charge a fee for clinicians utilizing their services. That's usually about a couple $100 per clinician. We'll talk more about how you can select registries or QCDRs based on your practice. If you are in a large practice of 25 or more eligible clinicians and submit to CMS that you are planning to report as a group, you can use the CMS web interface. This is a set of 15 predetermined clinical quality measures, and just as a side note, they are very primary care focused. So clinicians and specialty groups might not see a lot of patients that would meet the requirements of that handful of measures. If you are in a group of greater than 16 eligible clinicians, CMS will pull an all-cause readmission measure from administrative claims. You don't need to report anything to CMS. They will automatically pull this data for you. So these are the specialty measure sets. I apologize, it's a little small on the screen, but you do have access to these slides. As you can see, CMS has done a pretty good job, including quite a few specialties. There's definitely room for additional specialties to be included in future years of the program. There's also, as you can see, general practice and family medicine is considered a specialty. as well as internal medicine. Hospitalists are in there, preventative medicine. Take a look, see if anything suits your needs. In this year of the program, you are not required to report on measures only listed in your specialty. So let's say you happen to be a rheumatologist. I don't know off the top of my head how many measures are in the rheumatology measure set, but let's say there's 10, but only 3 apply to the patients that you typically see or fit your practice. You can also select then maybe 2 from the internal medicine group and maybe 1 from behavioral health. Maybe you see a lot of behavioral health patients. I don't know. I'm totally making that up. But you can pick and choose from the different groups. You're not limited to what is in your specialty measure set. However, something to consider is oftentimes if you select a registry for a QCDR specific to your specialty, they oftentimes only support those measures applicable to that specialty. So that's something to consider as you pick the measures that you want to report. There are bonus points available under the quality performance category. If you submit additional outcome or high priority measures, you can earn up to 2 bonus points per measure. 2 bonus points comes from the additional outcome measures and 1 from additional high priority measures. You're capped at a total of 10% of your base score. So for clinicians in practices of 15 or fewer eligible clinicians, that would be 6 points for this portion of the bonus. If you're in a larger practice, it would be 7 points. If you're utilizing a certified EHR system and you are able to pull that data directly from your EHR without any sort of manual abstraction, you can earn an additional bonus point per measure. So that's, again, up to 10% of your base score, which would be either 6 or 7 points for another bonus point percentage. This is a screenshot taken right from the CMS QPP website. This is under the quality performance category page. I just wanted to draw your attention to a few elements that you should consider as you start to look at the quality measures you might be reporting on. So the first arrow on the far left side is pointing at the measure number. So for this measure, it's the atrial fibrillation, atrial flutter, chronic anticoagulation therapy measure. So this measure doesn't have an e-measure ID or an e-measure NQF ID. However, it is NQF measure 1525, and the quality ID is the MIPS quality ID for this measure, so it's 326. Important to know. On the far right side, you can see the specialty measure set, and this measure actually fell into several specialty measure sets. I chose it based on the cardiology specialty measure. That was what I was looking at when I pulled this. But you can see which one is listed if you're interested in pulling that data. And then right in the middle at the bottom, you can see data submission methods. And this is really important to consider. So this measure is available for claims-based reporting and registry-based reporting only. As you start to look at the measures you're planning on reporting and what fits within your specialty, it's crucial to understand if these measures are available based on the measure submission method that you have chosen. So if you're planning on reporting EHR Direct, unfortunately, this measure would not be a measure you could choose because it's not supported for that method of submission. While we're talking about measure submission methods, it's crucial to also consider how you're planning on performing. So I don't get into scoring much today. That's pretty weighty topic, but depending on the measure submission method you select, that measure earns different decile points, and you can earn between 3 and 10 decile performance points for each quality measure you select. Now, the points available based on the percentage performance score you earn varies depending on the data submission method you select. So again, it's really important to know what submission method you're planning on using and how you plan to perform in the program or want to perform overall. Now I'm going to talk about qualified registries and then clinical data registries. So CMS has put together a list of the qualified registries for 2017. That link is at the top of the screen. As I mentioned before, it's really important to know what is supported by that registry. So I just picked a random one off the website. It's the American College of Surgeons, Surgeon-Specific Registry. Now, this registry is able to support performance categories of improvement activities and quality. So we'll talk about in a minute advancing care information. You would not be able to submit your advancing care information data through this registry. It can only support those two performance categories. The next important category to look at is the quality measures that are supported are only this handful of about 15 measures. So obviously that would cover your 6, but it's important to know, do those 15 or so meet the needs of their practice? So be sure to check that out. The measure right below, you can see if you're interested in it, it would accept all registry eligible quality measures. So some include all, some only allow for a smaller subset. If you're looking for a qualified clinical data registry, there's a separate link for that you can access on the top of the screen. I picked the American Academy of Allergy, Asthma, and Immunology QCDR. Again, as you can see, the supported performance categories are all 3 that you would need to report on this year: advancing care information, improvement activities, and quality. Again, they're only supporting a handful of MIPS quality measures, so be sure that if you select this, you can find the measures that you want to report on. An interesting element of QCDRs is that there might be measures that are not MIPS-supported quality measures. If you are reporting to a QCDR, you do have the opportunity to report on measures that might not be certified through MIPS, but are included in your QCDR since it's more applicable to your practice. But be sure to check on that because they do vary by registry that you select. The quality measure performance score is calculated by the total number of points you earn for each quality measure you report on. Any of those bonus points I mentioned over the maximum number of points, again, that's either 60 or 70, depending on the size of your practice, and you are capped at 100%. Advancing care information accounts for 25% of your MIPS performance scores. These are measures carried over right from the Meaningful Use program. We'll talk about what they are in just a moment. The total performance category score you can earn is 155%. You're capped at 100%. 50% of that comes from the base score. 90% of that comes from the performance measures. And you have an additional 15 bonus points available. Again, you must report for at least 90 days, and that must start no later than October 2nd. Slightly different on the quality category, you have the option to report via attestation, which, if you're familiar with Meaningful Use, is using a portal. You would manually key in the numerator and denominator and any exclusions for the measures you select. That portal is not yet available. We get a lot of questions about that. I'm thinking it will be available sometime later this year, maybe best case scenario November, December time, but we will definitely make anyone aware of its availability. Again, the other options are the same. Each are direct, registry or QCDR, and CMS web interface. So the base score for advancing care information is 2 different measure sets. If you're reporting through a 2014 certified electronic health record, you would be reporting the 2017 advancing care information transition measures, that is security risk analysis, e-prescribing, providing patients access to a portal, and health information exchange, which is sending an electronic summary of care document. If you are using a 2015 certified system, you have the option to use the 2017 transition measures, or you can use the advancing care information measures. The only difference is there is an additional measure, which is the request and accept the summary of care, which means that you're actually taking the data from the summary of care and embedding it into your electronic health record. If you receive a 0% performance, so basically 0 patients in your numerator for any of the numerator denominator measures, or you say no to the security risk analysis, you will not meet the base requirements, and your score for advancing care information would 0 across the board. You don't have an opportunity to earn performance points. The performance points that are available is 9 or 7, depending on the measure set that you select. Bonus points are available for reporting to a public health or clinical data registry. You can also earn bonus points for utilizing your EHR to report on certain improvement activities, which we will talk about a little more. Again, the Advancing Care Information Performance Score is made up by the base score plus the performance score plus the bonus score, and again, they're capped at 100%. There are Advancing Care Information hardship exemptions. So I know this is potentially a national call. If you happen to be in any of the regions of the country that were affected by any of the recent hurricanes, you most certainly can submit a hardship exemption that would qualify under the extreme and uncontrollable circumstances. If you have insufficient internet connectivity, if you're in a very rural setting, you could also submit a hardship. If your hardship exemption is accepted, the Advancing Care Information Performance Category score would automatically be reweighted to 0, and quality would account for 85% of your MIPS score. Now, if you remember me mentioning in the very beginning about the special status designations, if you are considered a hospital-based clinician or non-patient-facing clinician, your Advancing Care Information Performance Category score is automatically reweighted to 0, and quality would become 85% of your score. The same is the case for physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. Improvement activities. Improvement activities is a completely new category this year. It accounts for 15% of your performance score. We like to call these quality measures on steroids, at least that's what I call them. Really, they look at how you can improve workflow within your practice, patient engagement, population health management, really just making your practices the best they can possibly be. You must report on improvement activities for at least 90 days. These are all attestation-only measures, so you say yes or no, you're doing that, whatever the activity is. You don't actually have to provide CMS with any documentation at the initial time of attestation. Improvement activities are weighted either medium or high. Medium activities earn 10 points, and high activities earn 20. If you are in a practice of 15 or fewer eligible clinicians, you only need to report on 1 to 2 activities to earn full credit. So basically, they earn double points. So the maximum category score is 40 points. So each medium-weighted activity would be given 20 points, and high would be given 40. If you're in a larger practice, 16 or more clinicians, you must report on 2 to 4 activities to earn full credit. If your practice is PCMH recognized, or you have the patient-centered specialty designation, you earn full credit. You don't have to report on any additional improvement activities. There's over 90 activities to choose from in the following 8 categories. The really crucial thing to remember about improvement activities is that you must have supporting documentation. Because these are attestation only, CMS likely will audit this category pretty heavily. So be prepared. We always say be prepared to tell the story of what you have done to implement whatever the activity you choose is. So have agendas for meetings, notes for meetings, attendance lists. If you perform any sort of staff education where you do a quiz afterwards, have the quiz results. If you provide patients with educational materials, have examples, have the different methods that those patients can access those materials. Really make it a robust story of how you're telling the story of what you're doing. Again, improvement activities is the total number of points earned over the maximum number of points divided by 100. Here's a quick list of some improvement activities that you might want to consider. So evidence-based techniques for promoting self-management into usual care. That's, again, a patient education program. Implementation of formal quality improvement methods. So that's having those quality improvement meetings within your practice and then implementing changes that make a meaningful difference. Engaging patients, family, and caregivers in developing plans of care. Care transition documentation for practice improvement. So how are you improving those care transitions for all of your patients? The use of those qualified clinical data registries with feedback reports. Collecting and following up on patient experience and satisfaction data, and the implementation of specialist report back from referring clinicians. So making sure that you're closing that referral loop with the referring clinician that might be sending patients your way. And by the way, that's also a quality measure, closing the referral loop, so something to consider. As I mentioned, cost accounts for 0% of the MIPS score in 2017, but it's really important to know where your utilization rates are and your cost containment strategies. So be aware of where you're performing. CMS just released the 2016 Quality and Resource Use Reports, which have utilization data on them. They can be a little challenging to get a hold of, so please let us know if you're interested in getting your report, because we're more than happy to help you with that. And that score is calculated by taking the performance category score plus improvement activity score plus advancing care information score, dividing that by the percentage per category, and then multiplied by 100 will give you your final score. As I mentioned, if you choose not to perform, you earn a performance score of 0. That would get you a negative 4% payment adjustment. If you choose that crawl pace where you're doing the minimum amount of data, you would earn 3 performance points, which would get you a neutral payment adjustment. If you're in the 4 to 69 performance points, you would earn a small positive payment adjustment. And if you're in the 70-plus performance group, you earn a moderate positive payment adjustment and that option for an exceptional performer bonus. So really shoot for that if you can. As I mentioned, you're probably all sick of hearing me say it, October 2nd is the last day to start a 90-day reporting period. And just as a side note, data submission doesn't begin until January 1st. That's data submission to CMS, and it ends March 31st of next year, 2018. However, if you are either submitting claims data, which runs pretty much all year this year, 2017, or you're working within a registry, you might be able to start submitting data now, but it's important to work with them because they all have slightly different requirements. So what can you start doing now? If you're scratching your head thinking, oh man, I really haven't prepared, what should I be doing? Here's some steps. So first, determine if you're planning on reporting as either an individual or group. If you're a solo clinician, obviously you're reporting as an individual, but think about what makes the most sense for your practice. If you report as a group, you are reporting as a group across all performance categories, and your performance is aggregated across all of those performance categories. Choose what reporting pace you think you want to select. So that's the crawl, walk, or run. How many performance points are you planning on trying to achieve? Do you want to go for the exceptional performer bonus, or are you just trying to avoid a penalty? What data submission method will you select? So I mentioned claims for quality for individuals, attestations for advancing care information or improvement activities, EHR Direct, Registry, QCDR, and CMS Web Interface. And I didn't put it up as I mentioned, but keep in mind what data submission method you select does have an impact on your quality performance score. So we're happy to talk about the benchmarks with you if you have questions about that. Did you previously participate in any of the other programs I mentioned, so PQRS or Meaningful Use? What did your data look like? Did you do well? Did you receive a penalty? Do you feel comfortable with that type of reporting? If this all seems like old hat to you, then I would say try to continue performing at whatever level you performed in those programs and just continue the momentum forward. And as I mentioned before, make sure you have supporting documentation available, both for your performance, so any reports for quality and advancing care information, and then the documentation to support the improvement activities you are selecting. I'm going to briefly talk about the MSSP APMs. Those are the groups we typically see. I'll also just briefly mention the next-gen or other APM model. So if you're in a Medicare Shared Savings APM, 50% of your score comes from quality. This is data aggregated at the APM entity level. It will also be submitted to CMS through your APM entity using the CMS web interface for a full calendar year. Again, that's 15 clinical quality measures with a very heavy primary care focus. 30% of your score comes from advancing care information data submission. Now, in a Medicare Savings ACO, you have to submit your data by participant PIN. So I like using the analogy of a house. So think of the APM entity as your house, as a structure. And each room within that house is a participant PIN. So that's each of your practices. And then the people within each of the rooms are the clinicians working in those practices. Each of those participant PINs, so each of the rooms for advancing care information is kind of seen as its own entity. You will be submitting data on your own, or if your APM can assist you with it, if you use one single EHR. But your performance is weighted based on the number of clinicians in that participant PIN compared to all of the clinicians in the APM entity, and then it's aggregated up to one single APM entity score. Each participant PIN, they select their own 90-day reporting period, and you can also select your own data submission method. So you don't have to use one single 90-day period or submission method. You're allowed to select whatever works best for your practice. If you are in a next generation ACO, you have the same threshold, so 30% of your APM score. You do have the opportunity to report data as either participant PINs or individual eligible clinicians. CMS will look for the best possible score, and then the APM entity gets one, again, aggregated score. MSSP track ACOs also earn full credit for the improvement activity category, which is 20% based on their participation in an APM. If you were in an MIPS APM that is not a Medicare Shared Savings Track, so that would be the Comprehensive Primary Care Plus model, end-stage renal disease model, or oncology care model, you have slightly different reporting requirements, and I didn't put up a slide because there aren't as many, but quality is 0% of your score. That you just follow the contractual requirements of your APM. Advancing care information becomes 75% of your score, so it's really critical that you perform well in the data submission of EHR utilization. And you have the same options as next generation ACOs. You can submit as a participant PIN or an individual eligible clinician. And you do still receive full credit for improvement activities, but that category is weighted at 25% of your score, so you get slightly more points. But obviously, advancing care information is critical for that group to do well. Some resources. The top link is our New England QIN-QIO MACRA website. We have an Ask a Question link. You're more than welcome to submit questions to us. We're happy to help you. The next is the CMS QPT website that has really great resources on it. You can look up all of the different measures that are available. The next is the Council of Medical Specialty Societies website. Again, thank you, Dr. Khan, for supporting us today in this webinar. And the last I just want to call everyone's attention to quickly, CMS has generated a handful of specialty tip sheets. So I just looked at a couple. They have cardiology, emergency medicine, and ophthalmology. The tip sheets kind of go over the basic requirements of MIPS, and then some of the suggested measures within each of the performance categories to help you identify where you should be reporting. Helpful tools if you need some additional information. I will now open it up to questions. These are my dogs. If you know me, I always talk about dogs, but so those are my nicely crazy dogs. I do see 2 questions in chat that I'll answer quickly, but feel free, if you'd like to ask a question over the phone, please press #6 to unmute your line or submit a question in chat. So the first 2 questions here are, can you participate in Medicaid and Medicare if your providers are split between both Medicaid and the Medicare status? Are you referring to the Meaningful Use program? I'm not entirely sure which program you're referring to there, but yes. So you would continue reporting to Medicaid Meaningful Use if your clinicians meet that threshold. And yes, you could report to MIPS as well. And no, FQHCs are not exempt. Well, let me rephrase that. FQHCs are only exempt if you're not billing under Method 2. So if you do the bundled or kind of comprehensive billing, then FQHCs would be excluded. But if any portion of your claims hit the physician fee schedule, then you would be required to report through MIPS. Any other questions? Let's see. As a solo practitioner, how does one tell of your choices? Who and what one agency? I'm sorry, I'm not sure I completely understand the question. Choices in terms of who's eligible or what measures? We had another question for the crawl option. If you report on an improvement activity, that must be for 90 days minimum. Yes. If you choose to do one single improvement activity, it's for a minimum of 90 days. And make sure you have strong supporting documentation. I think I heard someone on the phone. You can go ahead.
Yeah, it's along the same lines. If you're doing one of the improvement activities, if you're doing the primary part of that activity during the 90 days, could it have started before the 90-day period began? For instance, if you did the satisfaction surveys and acting on the satisfaction surveys, the surveys were given, say, during the summer. Can you then count that as one of your improvement activities if you're continuing to build in improvements based on the findings?
Yeah, that's a great question. So if you started over the summer, since it's part of the 2017 performance year, I would say whenever you started your satisfaction survey assessment period, include that in your time frame of when you're administering the assessments and then analyzing the data and then making any adjustments in care. Because it sounds like you have more than 90 days, which would be fantastic, and you can always go over 90 days. You can't have less than 90 days.
Okay, thank you.
Absolutely. Let's see, I got two more questions here on chat. I was a little late signing in. I apologize. With regards to physical therapy, yes. Okay, so physical therapy, yes, you're excluded until 2019 based on the way the current legislation stands. That might change. I would say keep abreast of what the final rule looks like. So you don't need to start doing any reporting just yet, but definitely stay aware of what the requirements are.
I have a question.
Oh, yeah, absolutely. Go ahead.
The question really is, physically, how do you indicate? We're talking about what we need to have done and prepared and all that, but to whom do you report? Literally.
Sure.
Or is there, I'm a sole practitioner, I have an EHR that supports a lot of things, I'm going to be part of a registry. I still don't know, who has to indicate and to what degree do I have to indicate, and if I have the data for the whole year but I haven't put it into some format. All of these things that was not answered. I've been listening to things of this sort for years, and it's still not very clear. If you do this to tell that person or that agency what you have to do or what you've chosen, that's not clear to me.
Okay, so hopefully we can give you a little more clarity on that. Now, are you planning on using the registry to do your quality measure and EHR submission?
Yeah, I'm in process of joining an accredited one through neurology.
Okay.
They're doing a good job. But I'm not yet fully up to speed there. And I'm not sure whether the October 2nd thing is a look back or not. I'm not sure.
Yeah, absolutely. So, fantastic question. Thank you for addressing that, because I think a lot of clinicians are probably in a very similar place to your own. How exactly do I make this all meaningful, right, and do what I need to do? Excuse me. So, the 90 days, the October 2nd I'll start with, that's only to start a 90-day reporting period. If you're planning to report for a full calendar year, as long as you have the process in place to gather that data, you don't need to necessarily worry about the 90 days. If you are planning on starting, let's say, an improvement activity, you would need to start that by the October 2nd. It's really just to be thinking, okay, do I have the processes in place and the tools that I need to pull the data by this last 90-day period, but you can always go retroactive. So if you get to December, let's say 15th, and you think, I've done really well on all my quality measures, my advancing care information performance looks good, I have this handful of improvement activities ready to go, you most certainly can report for a full year. You don't have to say to CMS until you actually go to report what period of time you're selecting. So don't worry about that piece. In terms of using the registry, if you can get on the registry sooner rather than later, that would probably make your life easier. If you choose to report just solo, either through your EHR directly, the way the actual attestation works is from January 1st through March 31st of 2018. Once the portal is available, if you choose to use the portal, you as a clinician or any designee of yours would log into the system and submit the data to CMS on your behalf. So they would key in any values and make sure that all that data has been submitted to CMS, and then CMS will do on the back end evaluations of the quality of your data, determine your percentage of performance, and any incentive payments or penalties you are eligible for. If you use a registry or EHR Direct, those registries and EHR systems will submit the data on your behalf. So you won't need to worry about submitting anything to CMS. I would just say check in with them to make sure they have submit the data during that reporting period, which is, again, January 1st through March 31st of 2018. But it's really now just collecting the data, analyzing it to make sure it's accurate and demonstrates your best level of performance. But then you would be submitting it right to CMS, either on your own or having a designee do it for you.
Thank you.
Does that hopefully answer your question a little?
It's getting there, yes.
Okay. And feel free to reach out to us. Here's my contact information on the next slide. I'm more than happy to talk to you offline, and we can try to come up with a solution to make sure you feel very comfortable and confident that you have what you need to report. A couple more questions came in chat I just want to quickly address. So PQRS numbers 226 and PQRS 138 tobacco, are these measures that mirror? Off the top of my head, I can't say yes or no. I don't have the specs up, so I apologize. I can't give you a firm answer on your question about the tobacco use measures right now, but I'm happy to talk to you offline. Bonus score for ATI, can you please review the 5%? So for clinicians and groups that utilize a clinical health, clinical data or public health registry, there's about 5 to choose from, depends on the certification year of your EHR and the measure set that you select. But by reporting to one of those, you can earn a 5% bonus. You're topped out at 5%. If you participate in more than one, you can only earn 5% bonus. And then again, by selecting improvement activities that utilize your EHR, so that would be improvements to your patient portal and ensuring that patients have access to a portal, utilizing patient-reported outcome measures, employing increases in practice access through the use of maybe telemedicine and increasing patient communication methods with your stuff, you can get an additional 10% bonus points. Again, by reporting on more than one, you don't get more than 10, you're capped at 10. So hopefully that helps. We will receive a copy of the transcript. Yeah, so transcripts, recording, and slides will all be made available, I'd say, roughly in about a week. Be sure to check our website. And I believe that CMSS will also make this available to their members. So stay tuned.
Leila, it's Morgan. I'm actually going to put the link in chat for people to hang on to where the presentation is now, and then the transcript and recording will both be added.
Oh, fantastic. So there's that information. One more question. We do not use an EHR except for e-prescribing, so I don't understand. So yes, if you're not utilizing an EHR except for e-prescribing, you would get a 0 in the advancing care information measures. Small status does not get you an exemption, unfortunately, small practice status? If not, can we still get credit for the other categories? Absolutely. So if you get 0 in advancing care information, that by no means precludes you from getting an incentive payment. You can still get the maximum points based on your performance in both quality and improvement activities. So removing that 25%, you'd be capped at 75, but if you recall, 70% and above is how you get into that exceptional performer bonus, so you definitely still have opportunities. How do I print these slides? We'll make the link available so you can download those and print those on your own. Any other questions on the phone line that I missed? Any other questions in chat? Like I said, feel free to email us, either using our Ask a Question link or you can email me directly if you have questions. We, like I said, are here to help you. I didn't mention it before, but we're contractors of CMS. All of our services are provided at no cost to the clinicians and practices, so please feel free to utilize us. We're here to help you and make sure that you're successful. So, great. Well, hearing no additional questions, we'll give you 3 minutes back in your day. Thank you again for participating, and please fill out the evaluation before you leave. Have a great rest of your Tuesday.
Bye, Leela. Thank you.
The reader has just 5 minutes.